Oh, hello, good morning. Shall we start the meeting, the presentations?
Okay, Abdullah, I have already presented you to the group. Just to repeat, Dr. Abdullah Abu Zaid is our neurology registrar. He's going to present an interesting case, neurological case, followed by a discussion about this case. He will have some stops during the presentation to allow the audience to ask questions or to share ideas. Feel free to stop me or stop him at any time if you want to clarify anything. Dr. Abdullah, please proceed. The floor is yours.
Thanks, Dr. Salih, for the introductions, and good morning, everybody. Actually, in neurology, we have tremendous neurological symptoms that may save lives. That include, but not limited to, acute stroke or seizures. But basically, these kind of presentations usually seen by AR physicians or neurologists. Today, I'll be talking about neurological symptoms that may save lives that I believe can be seen by any specialty, either in clinic or in patient settings, as it is not an acute presentation. So I'll start briefly with case presentations and I will wrap my talk with topic review. So the chief complaint is dizziness, which is non-specific symptoms for 1 year, and unsteadiness for 6 months that prompt the patients to seek medical attention. So this is a middle-aged gentleman. He's a smoker. He has a progressive dizziness, which has been worsening slightly. It was coupled with dysarthria and unsteadiness with tendency to fall to the left. It was associated with intermittent paresthesia in the lower limb and distal upper limb. No history of dysphagia or dysphonia. No history of headache, divergence, diplopia, or ptosis. No history of weakness or facial asymmetry. No history of sphincter dysfunctions. No history of weight loss or night sweatings. No history of foraminal congestions or contact with TB patients. No history of recurrent mouth ulcers, genital ulcers, skin rashes, or joint pain. No history of cognitive impairment or apathy. He denied any psychiatric illness, personality changes, hallucinations, or delusions. No history of stroke, seizures, or loss of consciousness. No history of similar conditions in the past. He had history of trigeminal neuralgia 5 years ago, which was self-limited, and he receives no medications. He had hemorrhoids and left knee meniscus tear repair a few years ago. No specific diseases run in his family, no autoimmune diseases, apart from his son, who has DM type 1. He takes no medications, no non-drug allergies. He is a military, married with 6 siblings, all of them in a good health. He smokes 1 pack per day for more than 20 years. He is alcoholic in social basis and no history suggestive of dependence or abuse. Functionally, unfortunately, 4 months ago, he started to use cane to assist him in walking, and he was not able to walk for the last 1 month. He can take care of himself for daily livings, and he still is able to drive his car. So let's summarize the history. We have a middle-aged gentleman who is a smoker, and he's alcoholic drinkers presented with dizziness, subsequently followed with ataxia and dysarthria. Is accompanied by intermittent paresthesia. there is any questions or
Thank you, Dr. Abdullah Buzaid. I would suggest to clarify some pure neurological terms for the audience, since these terms are not commonly used in other specialties, such as apathy, which means lack of interest, and so on. Is there any questions about the history? So in summary, he is a guy that he presented with symptoms of ataxia and probable cerebellar involvement with questionable or intermittent sensory symptoms. Any questions at this point? And importantly, Dr. Abu Zaid denied any involvement of other neurological symptoms such as cortical involvement. The patient has no cognitive decline and no other associated non-neurological symptoms such as symptoms that may suggest vasculitis, joint pain, skin rash, and so on. He also has no contact with sick patient and no constitutional symptoms. So it is a subacute symptoms that evolve over a few months, progressively worsening, mainly cerebellar. If anyone has questions or anything need to be clarified, please feel free to ask, or we will proceed to the physical exam. Okay, Abu Zaid, can you please proceed
yeah, sure.
and give us your differential up to this point? Go
All
ahead, please.
right. Basically, in neurology, we almost always ask, where is the lesions? So we try to localize before getting to differential diagnosis. And we are trying to hit one lesions that explain all findings together. So the patient is having cerebellar dysfunctions in terms of ataxia and dysarthria as well. That might explain he has some sort of cerebellar dysfunctions. So to make your life easy, we classify localizations to two main parts. Is it centrals or is it peripheral? Central include, is it cortex, subcortex, basal ganglia, brainstem, spinal cord, or cerebellum, which I believe, based on history, most patients is having cerebellar will be on the top of possible lesions. And also we have peripheral, like start with anterior horn. Is it rods, plexus, nerve, neuromusculars, or muscles? So our patient is not having weakness, no fluctuations of weakness, which make neuromuscular junctions and muscles very unlikely. With intermittent paresthesia that make nerves, plexus, and rods is considerable in our lesions, localizations. So let's proceed with the physical
How
exam.
about central causes, Dr. Abu Zaid? You've mentioned cerebellar. Is there any other possibility? Cortex is probably unlikely. Subcortex as well, basic ganglia. How about brainstem or spinal cord?
Actually, patient doesn't have any dysphagia or respiratory symptoms, no sphincter dysfunctions that I believe will make it in the bottom of the list.
I see. How about sensory
Yeah,
ataxia?
yeah. Still, having said that, patients with ataxia will not necessarily will localize it to cerebellum. In fact, patients with the sensory ataxia, which is a part of peripheral, can present with anesthetic gait. So I believe if we proceed to physical examinations, we'll try to match the pictures.
Okay, please. Thank you.
So patience is conscious, alert-oriented time, place, and persons, not in distress or pain, doesn't seem to be pallors, sinews, or jaundice, and her mental state is intact. He has profound scanning speech, but is still able to comprehend. Language exam is intact, which include naming, repetitions, reading, writings, and comprehensions, all within normal. Pupil was 3 millimeter round and reactive to the lights bilaterally. Visual acuity and visual field were intact. Extraocular movement was intact as well, but there is a profound bilateral horizontal nystagmus, which is non-fatigable, and there is no ptosis or proptosis. And fundus exam is normal. No obvious facial asymmetry, no other cranial nerve involvements, no obvious atrophy or fasciculations by inspections, normal tone and sensations, normal powers 5 out of 5, proximals and distals, flexors and extensors, reflexes is +2 symmetricals in upper and lower limbs, and plantars downgoing. No signs suggestive of posterior column involvement, such as vibrations and joint positions, and no history suggests spinothalamic injury, no pain or temperatures, lesions. Cerebellar exams is notable for bilateral intentions, tremors, and finger to nose is impaired bilaterally, more notably on the left upper limb. So it was overshooting the targets. So which means he cannot touch the fingers, but he is all of a sudden overshooting the target. The gait patient was unable to walk in his own, and significant ataxia was observed on assisted ambulations. He failed to tandem and cannot stand on one foot, toes, or heels. Other systemic examinations, as he is alcoholic, we look for other signs suggestive of chronic alcoholic use, such as debutant contractures, pulmonary erythema, gynecomastia, or spider nevi. Other systemic exam that include cardiovascular, chest, abdomen was unrevealing. So let's summarize physical exam. There is a profound dysarthria with intact language and cognitions. Significant horizontal nystagmus bilaterally. Also, dysdeudokinesia and dysmetria was noted. The patient was unable to walk on his own, and significant ataxia was observed on assisted ambulations.
Thank you, Dr. Abu Zaid. Any questions up to this point? I think the physical exam had more information on the previous history. So basically, the exam confirmed the initial impression of cerebellar involvement. The sensory exam was largely unremarkable. So this make sensory ataxia less likely, which is basically a loss of position sensation, lead to ataxia mainly at gates. But the patient has other symptoms as well, suggestive of cerebellar involvement, such as dysarthria, scanning speech, which means the patient has separated words and has many pauses during the speech. So if anyone has comments, questions, or need more clarification based on what we have now, please feel free to ask. So, Dr. Abu Zaid, have you changed your differential diagnosis after these physical examination findings?
All right, so I would say again, what is the regions? Basically, localizations is like a puzzles. You try to gather informations from history, and you try to match it with physical findings, and to come up with one pictures that explain all the findings. Uh, to make your life much easier, just I would like to summarize an important way to differentiate clinically. Is it upper motor or is it lower motors lesions? Upper motor neurological signs that include hyperreflexia, hypertonia, which our patient did not have it, or spastics, and Babinski is usually positives. On the other hand, lower motor, which include hyperreflexia, hypotonia, and also usually the wasting is usually prominent, and fasciculations as well, where Babinski is most of the time is negatives. So we believe we are dealing with cerebellar dysfunctions rather than any sensory. And then after we localize the patients, we proceed with differential diagnosis. The possibility is it vasculars? I believe is unlikely as the presentation is not an acute. Is it infectious or inflammatory? Yeah, I believe it's possible. Is it traumatic? It's really unlikely. Patient has no history of trauma. Is it autoimmune or demyelinating? Yeah, I'll make it on top of the list, including the metabolics. And we usually would like to make idiopathic on the bottom of the list. So
Can you go back? Yes, please. So, Dr. Abu Zaid, this is a very useful way to think about differential diagnosis in neurological diseases as well as non-neurological diseases. It has a specific minimalic vitamins. If you look to the first letter for each category here, vitamin, vitamins. This is very helpful to organize your thought about differential diagnosis. Thank you, Abdullah, for involvement in all this. I think this is applicable for most of the neurological and non-neurological diseases. So based on what we have here, we almost ruled out a vascular and infectious as well. See, you've narrowed your differential as well. Top differential, you said autoimmune, and idiopathic will be down on the list. Please continue.
all right. We'll proceed with two investigations. We start with basic. That include CBC, electrolytes, coag, ESR, and CRB. All were within normal. Metabolic screenings, including for Wilson's.
So that make inflammatory infectious probably less likely with normal CRP ESR. Metabolic negative as well for possible Wilson.
Yeah. Also, autoimmune panels was included. Although the patient does not have any personal changes, we did NMDA, which was negatives as well. Also, a bunch of vitamins were ordered, including vitamin E, and were within normal. Vascular screenings were all within normal, apart from ANA, which is non-specific. And also celiac screenings, HIV, syphilis, brucella were all negatives. Therefore,
TB was sent as well, right?
yeah, it was negative.
So TB, brucella as well, negative. Okay.
So we proceeded with LB, which reveals no pleocytosis, no high proteins, no signs of infections, and gram stain and cultures were negatives. So after that, the patients presented with anesthetic gates, and we localized it earlier to the cerebellum. So I believe it's very relevant to ask for MRI brain. And we ask for it. As you can see, this is an MRI flare sequence, axial sections, which explain just mild atrophy in the cerebellum. So far, we understand the presentations and physical exam, as well as neuroimaging, support our the lesions physically and neuroimagically.
And we rule out some other differential based on what we have opposite. So demyelinating probably out up to this point. Infectious causes are out based on CSF results. What else?
Vitamins, metabolic, all were normal.
So probably we are ended by two differential autoimmune / neoplastic or probably idiopathic. How about genetic causes?
There is no history in the family of any similar conditions. That's why the probability was very low, and we did not ask for genetic testing.
Okay.
So at that time, we were thinking, was the cause he's alcoholic, which might explain his findings. However, we were thinking was other possibilities. So we have like an extensions of investigations in neurology. So what's called as paraneoplastics panels, which have been sent from CSF, which reveals anti-UAS detectables and anti-UAS very sky high. So we understand we are dealing with paraneoplastics as the most probable cause. And we try to dig deeper for any underlying malignancy, which include any CT, CAB, or PET scan stages of malignancy, tumor markers, colonoscopy, and ultrasounds of the scrotums, which were all negatives. So we proceed to how we manage these patients. We started with IVIG for 5 days, then followed by cyclic IVIG every 4 to 6 weeks. And then we keep following the patients, any screenings for underlying malignancy every 6 to 12 months. Unfortunately, patients did not show any significant improvement. However, we keep screening the patients every 6 to 12 months as there is high associations to pick up any malignancy down the road. It's worth to mention a few months after, patients went to Germany to seek for a second opinion, and he had thorough investigations, and turned out to be paraneoplastics with the specific anti-HU and anti-U were elevated. Additionally, any hidden or occult malignancy have been investigated thoroughly and did not show any significant underlying malignancy. Also, I would like to mention these kind of paraneoplastics, we can classify it to two kinds. Is it there is underlying malignancies? If you pick it up and you eradicate it or remove it, the prognosis usually far way much better than if there is no underlying malignancy. If there is no underlying malignancy, despite possibility of IVIG that may improve the outcomes, still the neurological deficit can be profound. And believe it or not, Even if you keep tracking or screenings for any underlying tumors lifelong, the patients might die and you'd not reach any diagnosis unless you do autopsy. Therefore, 2 years after presentations, while we keeping tracking any underlying malignancy, patients shows in PET scan increased metabolic activity in the prostate, which raised the possibility of CA. Accordingly, we refer the patients to urology to investigate him further of positive CA, and we believe if we remove his or treat his prostate, will save his lives, as well as his neurological deficit might be improved. So, all right.
Thank you, Dr. Abu Zaid. Is there any questions about the case before we proceed about the discussion? Any questions? So, do you know, Dr. Abu Zaid, what happened with the increased metabolic activity in the prostate? Was it investigated or not yet?
Yeah, actually, when he was seen by urology, the
and how long this was discovered after the presentation? 2 years?
Yeah.
2 years after the presentation.
Yeah, 2 years after presentations, the suspicious of prostate CA was raised, referred to the urology, and they tracking the PSA. PSA is still normal, and I believe they will keep follow up the patients in the PET scan as well as monitoring PSA, and they will see the levels and accordingly will manage the patients.
Interesting. How about the CT chest to look for small cell lung cancer?
Yeah.
Is it normal multiple times?
Yeah. It's worth to mention the paraneoplastic panels, which was positive for these patients, which is NTU and NTU. It is highly associated with the small cell lung cancer, and also it can be seen with the prostate CA.
Interesting. So CT chest high resolution was negative multiple times as well, which is not uncommon with paraneoplastic. Sometimes they, as you know, sometimes they develop malignancy later on, as you have mentioned earlier. Sometimes it's hard to be discovered without doing autopsy. So it is about 2 years now after the presentation, and we have not reached any specific diagnosis of malignancy apart from this possibility of prostate involvement. Any questions? Please proceed, Abu Zaid. Dr. Abu Zaid.
All right. So the last part is I will talk briefly about paraneoplastic syndromes in like 10 to 15 minutes. So what is the paraneoplastic syndrome? So it's a group of rare disorders that are triggered by abnormal immune systems response to underlying malignant tumors. Patients with paraneoplastic neurological syndromes most often present with underlying neurological before tumor is detected. And it's quite rare.
Can I stop you here, Dr. Abu Zaid? Sorry, I apologize for multiple stops. I can go back to the previous slide. I just have a comment about the first description. It's important to mention that these syndromes or disorders, as you've mentioned, it has to be caused by any mechanism other than the cancer itself, like metastasis or cancer-induced coagulopathy or chemotherapy side effects, nutritional deficiency due to cancer, or metabolic abnormalities. So all the abnormalities that can be associated with cancer patient has to be ruled out before you call it paraneoplastic. All the possible side effect of cancer drugs, metastasis, or the tumor invasion itself.
Yes, thanks, Dr. Salih, for your comments. Basically, the paraneoplastic is very rare. It affects 1 in 100,000 patients, with a few exceptions. The lumbar ethans can be associated with 3% of patients with a small CA. And also myasthenia gravis can be associated with 15% of patients with thymoma. And also these kind of cases or paraneoplastic is well known. And if there is associations with these kinds, usually the outcome is very, very favorable. Demyelinating peripheral neuropathy, which affect 50% of patients with rare osteosclerotic form of plasmacytoma. And again, paraneoplastic syndromes can affect any portions of CNS, from central to peripheral, starting from cortex down to the muscles. Unfortunately, usually the treatment is unrewarding. Most of the patients left with severe neurological disability, and even the immunosuppressions will not benefit the patients much, except lumbar ethans and myasthenia gravis. Now I'll talk briefly about classics forms of paraneoplastic presentations or paraneoplastic syndromes that include lumbar ethans, opsoclonus, myoclonus, which usually found in children. However, it can be seen in adult, subacute cerebellar degenerations, encephalomyelitis, subacute motor neuropathy, and lastly, we'll touch on sensory neuropathy briefly. So we'll start with the diagnosis of our patient, the paraneoplastic syndrome, cerebellar degenerations, which is the most common kind of paraneoplastics. So it is a disorders can be separated by characteristic antibodies, specifically anti-Hu and anti-U. And this paraneoplastic is usually associated with lung CA, specifically small cell, ovarians, uterine, and lymphoma. And as in our patients, cancer is usually found between 2 to 4 years after the onset of neurological symptoms, and sometimes even at just only at autopsy. The clinical features usually like what patients present, which is typical presentations of incoordinations, which can be rapidly evolving to gait ataxia, and incoordinations associated with nystagmus and dysarthria. Unfortunately, most of the patients cannot walk unsupported. Handwriting is impossible. They will not be able to eat independently, and they might not see clearly because of epilepsy. Additionally, patients have like dysphagia in the later stage, and also can get cognitive impairment like dementia. The lab that can help is CSF. Sometimes it can show pleocytosis with oligoclonal bands, will be positives, but will be transient. It's unlike MS. MS patients, if we find any oligoclonal bands positives, it's going to be persistent lifelong. Additionally, having normal MRI will not exclude paraneoplastic cerebellar degenerations, because sometimes many cases, even if you do MRI, will be normals, but still the possibility is there. And this is most common and autoantibodies, which is seen sometimes in serum and CSF. Also, it's important to mention, if you investigate the patients for paraneoplastic, please ask from serum and CSF. Having normal paraneoplastic panels in the serum will not exclusively exclude paraneoplastics. So anti-U is associated with ovary and breast, and also can be seen with the small cell lung CA, like with anti-HU. Anti-TR is associated with Hodgkin's lymphoma. And lastly, MA protein can be associated with testicular masses. Pathologically, usually
Dr.
cerebellum
Abu
is
Zaid,
atrophied. Yeah,
can you allow me to comment about this?
sure.
Thank you. So these antibodies are directly against intracellular neuron proteins, which is almost always associated with cancer. So they are highly, as you have mentioned, highly associated with cancer. There are other types of antibodies that are directly against cell surface or synaptic on the synapses on the cell wall, such as NMDA, AMBA, and GABA receptors antibodies. These antibodies the other group of antibodies are not always associated with cancer, and they may only present with autoimmune syndromes. So presence of the other type of antibodies does not always associated with cancer. On the other hand, these antibodies on this slide are almost always associated with cancer, and these patients need screening initially every 4 to 6 months and for at least 5 years. Thank you, Dr. Abu Zaid, and I apologize for this stop.
Thanks, Dr. Salih, for your comments. So we'll proceed for pathological findings in paraneoplastic cerebellar degenerations, which include there is cerebellum is atrophied, and microscopically there is a loss of Purkinje cells of cerebellar cortex. It's very important when you suspect paraneoplastic cerebellar degenerations to exclude any mimickers such as leptomeningeal meds, infectious, any toxicity of chemotherapy, viral brain stem encephalitis, demyelinating, as can be misleading with oligoclonal bands, with subacute presentations, CGD, and infarctions or alcoholic. The other form, classic form, is sensory neuronopathy, which represent less than 20% of paraneoplastics. It can be associated with Sjogren. As a matter of fact, 2/3 of paraneoplastic sensory neuropathy have a small cell lung CA. And the presentations is usually severe sensory ataxia, and all sensory modality will be affected, including the loss of deep tendon reflexes. The other one form is subacute motor neuropathy, which can be a marker of ALS. It is a rare complications of Hodgkin's. It can represent less than 3% of cases of paraneoplastics. And it's usually like other paraneoplastics syndromes, it is subacute, it can progress, it's mainly painless, and it can affect the lower limb more than upper limbs. And the characteristic finding in this paraneoplastics is profound weakness. The other form is limbic encephalitis, which usually patients presented with mood changes or personality changes, and sometimes the complications of a small cell lung CA. And MRI typically shows medial temporal loop high signals. So this is multiple MRI at axial sections in different levels. It is a flare sequence. As you can see, there is left temporal high signals. It's worth to mention having normal MRI will not exclude limbic encephalitis. So the other form is obsoclonus myoclonus, which is usually found in children's. Obsoclonus mean is involuntary, arrhythmic, multidirectional, high amplitude of conjugate saccade. It is associated with myoclonus, and also patients may have cerebellar signs. In fact, 50% of children with obsoclonus myoclonus end up having a neuroblastoma. The antibody associated with this syndrome is anti-RI antibody. Lambert-Eaton syndromes, I believe, is well known to everybody. It is 50% associated with small cell lung CA, and the outcome is very favorable. It's usually affecting lower limb proximally, and then it kind of progresses to upper limbs. Characteristically, there is autonomic dysfunctions such as dry mouth, dry eyes, impotence, orthostatic hypotensions. And one way to differentiate Lambert-Eaton's with myasthenia gravis, that there is no craniobulbar or respiratory involvement, in contrast to myasthenia gravis, which is usually prominent features. Also, nerve conduction study or EMG can help to rule in Lambert-Eaton's, which shows repetitive nerve stimulations usually will make facilitations responses. So unlike other paraneoplastic syndromes, like what I mentioned earlier, usually they respond to the treatment such as Blix, corticosteroids, Imuran, or even IVIG. And long-term treatments is often needed. So that's it. And to recap, if there is no comment, paraneoplastic cerebellar degeneration is the most common paraneoplastic syndromes affecting the brain. It's characterized by subacute onset of gait ataxia, progressing to truncal and limb ataxia, with dysarthria and often nystagmus with diplopia. Early recognitions of new onset cerebellar dysfunctions is therefore crucial, as it may be the main presenting features of an occult tumor. MRI, however, is remarkable in NTO-positive paraneoplastic cerebellar degenerations. Although abnormalities such as cerebellar atrophy can be seen, especially during the later stage of the disease. Ultimately, the prognosis of NTO-positive paraneoplastic cerebellar degenerations is unfortunately quite poor, as even chemotherapy or other treatment of primary tumor rarely results in improved outcome. Despite successful treatment of a primary tumor in many cases, the paraneoplastic symptoms often continue to have more significant negative impact on patients' quality of life than it does the underlying disease. So the take-home message, please, almost always consider paraneoplastic syndromes in your differentials, as it may save life. And thanks so much.
Thank you, Dr. Abu Zaid, for this comprehensive, informative review of paraneoplastic syndromes. If there is any questions, please feel free to ask for the audience, or any comments, anything need to be clarified. Thank you so much for Dr. Abu Zaid. Thank you so much for all of you for your attendance. I think we will conclude this meeting.
Thank you all.